Welcome along to the Pelvic Pod. I'm Jen Bainbridge, and Continence NZ have asked me to have some real honest conversations about something that affects so many of us. But we really are not talking about continence. It is bladder and bowel leakage or incontinence, and it is incredibly common. You'd be so surprised. About 1 in 4 New Zealanders are dealing with it. Yet so many people are feeling too embarrassed to bring it up or ask for any help, even though it can really impact their lives. So that's exactly what Continence NZ wants to change. And their mission is to empower people living with incontinence to not just cope, but to truly thrive. And they believe that starts with an open conversation. So here we are. This is the kind of conversation we want to normalise talking about these things, these topics, so that more people feel comfortable reaching out for that support. But here's what you need to know. You're not alone. So thanks for being here to listen, and let's get into it. I am so excited to introduce my first 2 guests. Both these ladies have dedicated their careers to helping people navigate bladder and bowel health. Dr Megan Ogilvie is an endocrinologist with a passion for helping people understand how hormones impact every aspect of their health. With expertise in conditions affecting the endocrine system, from thyroid disorders to diabetes and hormonal imbalances, Megan brings both clinical knowledge and a compassionate approach to her work. She's dedicated to empowering her patients with information that they need to take control of their health and well-being. While Hannah Orr marries nicely with Megan, she is a pelvic physiotherapist who specialises in helping people overcome pelvic floor challenges, including incontinence, pelvic pain, and postnatal recovery. With a deep understanding of how the pelvic floor functions and what can go wrong with it, Hannah is passionate about breaking down the stigma around these issues and giving people practical tools to improve their quality of life. Her approach is warm, evidence-based, and focused on helping her clients feel strong and confident in their bodies. Welcome, ladies.
Thank you, Jen. It's a very nice introduction.
That was good. It's just Kiwis don't like being talked up.
I know.
I was thinking, I hope I don't make you too uncomfortable. But honestly, you really are, trailblazers in your line of work. And it's so wonderful to have you here to talk about these issues that, as I said, we're not talking about. It's not a conversation that's being had. When I'm out having a glass of wine with my friends, it's not a discussion really you want to talk about, except that I'm getting up to the loo quite a few extra times at this age as I'm getting a little bit older. And so it's wonderful to have you ladies here to start this conversation. And firstly, let's just start, and we'll start with you, Megan, about just hearing about how your work relates to pelvic health and continence.
Thank you. I'm an endocrinologist, I'm a hormone specialist, and my subspecialty interest is reproductive hormones. So there's 3 broad areas that I'm working with all the time in the pelvic floor. So I look after women who are hormone deficient, and clearly the most common reason for being hormone deficient is being perimenopausal or menopausal. And the pelvic floor is so reliant on hormones that we commonly see issues there. We deal quite a lot with women who have conditions that set up some chronic pelvic pain, so endometriosis, vaginismus, pelvic physios, and pelvic floor work is really important for those women. And then finally, women who are born with variations of sexual characteristics, so perhaps with vaginal absence or shortened vaginal canals, and we can really help those women as well with gynae physio work, dilators, and really change quality of life for them.
That's amazing. Absolutely amazing work. And what about you, Hannah?
Well, I'm a pelvic floor physio, so it's all things pelvic floor. So bladder, bowel, prolapse, pelvic pain, how you use your pelvis, so whether that's for sexual pleasure or riding on a bike, going for a run, and see both men and women in that kind of all pelvic floor region.
And what are the most common issues? I suppose that's such a wide-reaching question, but the most common questions issues that people are bringing to you on a daily basis.
So I personally see lots of pelvic pain. So that's women who experience persistent pelvic pain, or they have to go to the toilet a lot because their bladder is painful, or they can't have penetrative intercourse. But
is that quite common?
Yes. Yep.
Is that
super common? Well, common in the group that I see, yes. Yeah. So I'd say like 1 in 10 women have endometriosis, and then they tend to have a lot of pelvic floor pain symptoms or bladder pain symptoms or irritable bowel symptoms. But bladder incontinence is so common. So I think it's about 50% of women in the kind of perimenopause, postmenopause will have bladder leakage. They tend to come and see me once it starts impacting their quality of life.
Yeah.
Lots of us, I think, can live with a little bit of like bladder leakage, and it's not a big deal. It doesn't kind of stop you living your life. It's once it gets to the point that it's interfering that you kind of want to seek help. Yeah, bladder and bowel, yep. So I see lots of bowels as well.
Interesting. And what about you, Megan? What is the most common, I'd say, thing that you're seeing come through your practice?
The most common thing I am seeing is bladder dysfunction in the perimenopause and menopause time. I think, just echoing your comments, more and more and more I've learned to screen for these conditions, because women won't talk about it, but equally women come into a medical consultation and it's not the first thing that they will talk about, and often they are looking for an opening question to actually have these discussions. So I proactively screen now almost every woman over the age of 40 and anyone I'm concerned about younger than that for urgency, frequency, do you have vaginal dryness or irritation, and are you leaking at all, common questions. And then women will start to open up and talk about what's going on for them.
I love that. So it's like,
With
right,
relief.
let's get the elephant out of the room. How's your bladder? That's so funny, because before I sort of came to knowledge around this topic, I never thought about bladder being a menopause thing, even though I'm perimenopause myself. I never would have made the link, just because it's not something I know much about really, that was linked. So
and yet it's so incredibly common, and I think one of the most important reasons that I screen for it is a lack of understanding that women have that it is progressive. So it's really the one menopausal symptom that will get worse rather than better with time. Those tissues are so estrogen sensitive, and I often say to women that it is much easier to hold on to tissue than try to grow it back. So we're much better off hitting it early, cutting it short quick, and getting it while women are only got mild symptoms, because they will get worse. And if you don't proactively manage these symptoms, they will really start to dominate your life in your 70s and 80s. Much harder to actually manage it then. Would you agree with that?
Oh, absolutely. And I think also what happens is you've got a cascade of things happening. And so say you have a bit of urgency, and so you're like, okay, I'll just go to the toilet just in case. And then so you develop this pattern of behaviour, which your brain learns, and that only gets worse. And then you reduce your fluid intake. Then you add a bit of weight gain, a little bit of muscle loss, and you can just see how it goes from something that's a mild inconvenience, you can kind of manage it, to it's actually taken over your life.
100%.
Yeah. So
what
early
do you
intervention.
think is stopping people talking about this though, Megan? Because you're saying you're proactively asking them. What's stopping people bringing this up?
I think embarrassment and shame and a lack of understanding that it will worsen unless you start to proactively manage it.
Yeah, because the one comment you just made there about the tissues are so estrogen sensitive. Again, that's not something I've heard discussed ever, actually.
No.
So that's so important for people to know that, right, Hannah? It's crazy.
Yeah, you've got estrogen receptors in your muscles, in your brain, and
and through your urethra, through your bladder, and clearly through your uterus as well. But there's estrogen, all of those tissues are estrogen impacted.
So give me an example of a client, like an actual story of a client that has come to you with an issue, and how that sort of treatment process has gone.
So women will typically come in with some symptoms. They might be getting irregular periods, they're not sleeping, they're getting flushes, mood might be a bit low. And then you ask them about what's going on with their bladder, and they will talk about some urgency and frequency, perhaps needing to get up at night to pass urine is a new symptom. They haven't had that issue before. Yeah. And then you say to them, okay, that's fine. What about when you walk in the front door at home? And they will say, well, often I don't make it. I've just peed when I've left work. I walk in the front door and then often I don't make it. And so, or I sneeze or I cough, I don't jump on the trampoline anymore. Those are the common type of things that women will talk to me about. I will start almost all of them on vaginal estrogen creams.
Right. Okay.
And then I tend to do a little bit. I'm nowhere near as comprehensive as what Hannah does, but I might say how your pelvic floor exercise is going and talk to them a little bit about distraction techniques with their urge difficulties.
And what do you mean by distraction techniques?
Do you want to talk about that?
Well, basically, your bladder's controlled by your brain. So if you arrive home, put the key in the door, and you are busting to go to the toilet,
Yes.
your bladder doesn't have eyes or ears. Your brain, which is an organ of prediction, and it learns from how it's experienced the world, will go, hey, we're at the front door. I know what we need to do here. And it basically takes the brake off your bladder, and your bladder's like, ready to go. So it's teaching, so it's keeping your brain busy, basically. So busy that it doesn't see you put the key in the door and preemptively take the brake off the bladder. That's what I mean by learning. Like, it's really easy to teach our brain to go to the toilet more often and to feel like we need to go more often. And that's what you want to catch early.
Like almost telling you, predicting it yourself. Oh, I know I'm going to be busting when I get home. And so it's expecting that, right?
Yes, and so it's very subconscious, and then once you've leaked, then that becomes a bit of an anxious cycle as well. So it is, it's lots of strategies on bladder retraining and keeping that bladder nice and calm.
Absolutely. And so we're doing the cream. We're talking about the pelvic floor.
So I do a little bit, but I'm very quick to refer. And I find the women that follow through, I think it's quite big and scary. Most women don't really know what a gynae physio does, and you need to have a bit of a conversation about what you do. And then it's quite scary to ring the first time to make the appointment or send the email. But the women that follow through with that come back to me and say, I wish I'd done that process 5 years ago because I've wasted 5 years of struggling with that issue. The women who go through to see a gynae physio have such a better outcome than the women who kind of struggle along and just hope it'll get better.
So you really do work together. So it was great to get you both in the same room, really, wasn't it? So then they come to you, and then what do you do?
Well, it's really interesting because I had a patient the other day who had had this problem since her first child, which was in her mid-20s.
Yeah.
She was now 70. Hadn't done anything, but Megan said she'd swapped endocrinologist because it was for a thyroid issue, and you'd screened. And she was like, wow, I can do something about this. It was it was perfect example. So I will look at what's going on. So often do a bit of a bladder diary just to get a gauge of severity.
Yeah.
And then it's really managing kind of behavioural things that have come around it. So if you've restricted fluids and not drinking enough or drinking too much, lots of big drinking habits as well can be a bit of a problem. Maybe looking at coffee, alcohol, those kind of things.
See, I do that. Is that hormones? I'm really thirsty.
Yeah.
Could be, eh? Yeah.
Also, you can train your thirst to drink, it can become a bit of a habit.
Yeah, right.
So, but looking at that, and then obviously looking at pelvic floor muscles and what they're doing, how strong they are, how well or effectively women are using their pelvic floor muscles. So that will be part of it. I use a lot of what we call T10S, so using a TENS machine to help calm that bladder overactivity.
Really? Yeah.
Yep, so it can be a really useful tool to have in the treatment plan. So bit of, and extra stuff, so, looking at exercise and weight management and things like that.
Absolutely. So next we sort of go on to that broader part. So first you've talked about how the tissue is estrogen sensitive, right? So obviously during perimenopause and menopause there is that hormone shift that affects the bladder health and pelvic function in general. And so tell me a bit about that, a bit more about that, other than the fact that the estrogen is affecting the tissue and then that's making the bladder weak. What more do we need to know about that?
I think that the tissue becomes thin and friable, and it becomes thin through the vulval area up into the vaginal canal. And remember, the neck of the urethra passes through the vulval area, but the estrogen receptors are also through the urethra in the bladder. And so this means not only does the tissue become thin and atrophied, but also the margins between the cells become a bit weaker and split apart a bit. And so that makes it a perfect environment for bugs to come in. And that's why women are getting recurrent urinary tract infections.
I was going to ask you that.
Over this time as well. The pH of the vagina has changed, and so the bacteria colonizing the vagina are not so much the healthy colonization that women have in their reproductive years, but perhaps more bacteria that makes them more prone to urinary tract infections.
Well, how can we stop those? I don't want those.
Estrogen. Look, vaginal estrogen creams are so important for women. They're not going to increase your risk of anything. The only woman that has to be cautious is somebody who's had a breast cancer diagnosis and is using an aromatase inhibitor. Okay. I think we are all very comfortable with almost all other women using vaginal estrogen creams. They're safe. They are slightly messy, to be fair, but they will protect that tissue, and they might well keep you out of a rest home at 80 because you maintain your continence. Really? So using them forever, not just using them 6 weeks leading up to a smear and then forgetting about them. Yeah. Using them forever is really important.
Is there a natural one? Does that exist?
So there are vaginal moisturizers. Yeah. And the moisturizers fall into two categories. There's moisturizers that will be just like putting Vaseline intensive care on your face and just give you a little bit more moisture. Yeah. And then there's moisturizers like Vagisil or Replens that will plump up the vaginal wall. But the bottom line is nothing is as good as estrogen creams. And in New Zealand, we've got Ovestin. That's what we use, but there are other products available overseas.
And can you get that prescribed or?
Yeah, you can get it prescribed.
Okay. Yeah. Because so it starts with that. So is that sort of like the gateway to HRT?
It's one of the options.
Or it's just one of the options.
With HRT. But I think, personally, anybody who is menopausal not using systemic hormone therapy should be using vaginal estrogen.
At least.
And many women who are using hormone therapy should also be using vaginal estrogen creams.
Yes. And at what point do we need to start doing that? Because I'm starting to get just having a wee hot flush. I'll be all right. You know, that's starting to happen. And I'm getting the night sweats and that sort of stuff at my age. And so at what point are we sort of thinking that we need to start doing that?
Creams or systemic hormone therapy? Creams, I tend to wait until women are a little bit symptomatic. Yeah, right. Because they are a bit messy and they are a bit of a faff. So it comes, in New Zealand, Ovestin is fully funded. It comes as a cream or a pessary. Pessary looks a bit like a waxy tampon. Yeah. So you use it as a loading dose every night for 2 weeks and then 2 nights a week after that. Okay. You get a bit of discharge with it. Okay. It's useful to wear a panty liner. Yeah. And the cream comes with an applicator, which you can either use to draw up the dose and insert into the vaginal canal, or you can just use to draw up the dose and put it on your finger and push it up into the vaginal canal.
A little bit like that.
Yeah. And then if women have urinary symptoms, I actually tell them to put a pea-sized amount on their finger and put it around the urethra as well. So that's what I mean about a bit messy. The applicator needs to be washed, and the pessaries can sometimes just give a grainy kind of discharge.
Right. So what's the alternative if women don't want to be messy like that?
So there are E-strings available a little bit in New Zealand. Some of the gynecologists are putting them in. They look a bit like a ring pessary, and they leach out a bit of estrogen each day, and they get changed every 3 months. They're not funded. They're about $220 per pessary, so every 3 months. But the specialists are teaching women to remove them and put them back in themselves. Are you involved with that at all?
Oh, really? No, but I have talked to one of the gynecologists who's working with it.
Is that to save money? Is that why they're teaching them to put it in and out themselves?
And mostly, many women can.
Yeah.
So it takes away the need for an appointment every 3 months. Most women can do it themselves once they're taught.
Because there is the pessary that also holds up the vaginal walls as well. So it gives everything a bit of support. So they're taking it out as well just to give the tissue a break and put it back in.
Interesting.
Yeah.
That is so fascinating. So this is all things that I don't know anything about, and I should know that. Shouldn't I? At my age, when I'm getting into this stage, that's why this conversation is so important. This is not really stuff I've heard people talk about, and especially to know that there's several options.
There are several options. There are also less funded options available from Australia because, unfortunately, we seem to think that Ovestin is the only medication required in New Zealand, and there are some women that just don't tolerate Ovestin. They find it irritating.
Yeah.
There is Vagifem, which we can get from Australia unfunded, and actually there is a new product called Intrarosa, which is intravaginal DHEA, which is also really good management for this condition. So there are certainly options.
That's great. Yeah, because somebody was saying to me yesterday about patches, you need some patches.
Yeah.
No one's really talks about the creams.
Yeah.
I was thinking, not really, I don't think I'm ready yet for that.
So that's
different
systemic
again, right?
hormone therapy. Yeah. And for somebody who's presenting with flushes and sweats, it really comes down to, does this symptom bug me enough that I want to use a medication to manage it?
Yeah, it doesn't bug me enough
question.
At the moment. Yes. At the moment, I just find it entertaining. Sorry everyone, don't mind me. But no, I hear what you're saying. It's about what you're willing to tolerate, isn't it?
Yeah.
So Hannah, then we go on to bone health and its connection with menopause and the pelvic floor strength. Can you speak to that a little bit?
Well, my segue would be, so you do lose, that's what Megan will talk about, you do lose bone density post-menopause because estrogen is such an important part of that. But if you are incontinent, you might then restrict exercise. So exercise can be a big provocator of leaking, so maybe running or lifting weights. You become more sedentary. Exercise is very important for maintaining bone density. So lifting weights, that tension from the muscle helps to keep our bone density high, or high impact exercise, so loading, like running or walking. Yeah. If you stop doing that, you're going to speed up or escalate your bone loss. So that would be the link I would see from a physio perspective.
Yeah, I've started doing, I've got into squatting in my 40s and weighted squatting. I'm getting quite hard out with it, and I'm really enjoying it. And I actually feel like a real rush from doing that. And I've lost a lot of weight from working out as well, because I knew I needed to at this stage in life.
Yeah, and that's where I start to see a lot of women. So you'll get to perimenopause, you'll start putting on a bit of weight. You're like, right, that's it. I'm going to go to the gym. You go to the gym and you're like, hang on a minute, things have changed down there.
Leaking.
Yeah, there's a bulge coming out every time I squat. And so, yes, a great time to go. I might just go have a warrant of fitness with the physio, especially if you did have a few babies or vaginal deliveries and you're like, I don't really know where it's all at the moment, just to screen and prevent. Perimenopause is your time to prevent.
Yes.
Also, I would add to that, I see some women too who get to exactly that point. They haven't really exercised for a number of years. They go and join a gym. They get an enthusiastic young personal trainer who doesn't understand about protecting the pelvic floor.
Nice.
And so the message to those women is it's absolutely fabulous that you're going off to start to do some exercise.
Yes.
If you're, please protect your pelvic floor as you do that. Quiz your personal trainer and make sure they understand how important that is.
And if they don't?
Well, I think it's quite hard for them too. I think often it comes from you understanding your own body. And so that's again where I'm such an advocate of physio, because it just helps you understand your pelvic floor. It's invisible. You can't see it. You often don't know, like straining. Lots of women will kind of bear down or push down through their pelvic floor. They might do that when they're trying to do pelvic floor exercises. And so if you can understand that, if you can kind of leave a physio session and go, all right, this is kind of load my pelvic floor. This is where my pelvic floor is in support. If you have sustained any trauma to your pelvic floor that you don't know about, that gives you much more agency. Because I do think a good personal trainer can have a look at what exercises are going to be slightly more high impact, make sure you're breathing through those exercises, but they don't know if you've got significant trauma to that pelvic floor and there's a prolapse about to come down where it might not be symptomatic for you. And then a few training sessions and it is symptomatic, which... So yes, I would...
Is prolapse just postnatal? Is that the only time it happens?
No, so you can develop prolapse without having a vaginal delivery, but that's one of the biggest contributing factors to prolapse. But a lot of women, it is over time. So you kind of sustain a bit of trauma to the pelvic floor muscles. They're not helping support. And then over time, loading, and then you get changes in the estrogen tissue quality. And then, you might add a bit of weight, and you might then go to the gym and do a bit of exercise. And then that's what kind of is the I guess, the straw that broke the camel's back. Like it can be one of those progressive type things. So again, so useful to look at physio as a preventive type decision.
Again, we just don't do that though, do we? We're reactive. We're not proactive, are we?
Well, I think it's life admin. There's just so many things that you have to do. And you're like, I'm finally going to the gym, and you're feeling great about that you're like, another thing. But like, even just one session, I think, because that gives you a little bit of insight. But the next question I have is around misconceptions. So what are the misconceptions you commonly encounter from your clients about how hormones and bladder health change, I guess? Is there something you could speak to around that question?
I think the commonest misconception is that this isn't going to worsen, that if they just ignore it, it'll go away and they don't need to worry. And talking to women about it getting worse, I say to women that the perimenopause and menopause is a real window of opportunity time to shape health and well-being for the next 30 years. And genitourinary health is part of that. So heart health, bone health, brain health, absolutely. But here we're talking about genitourinary health. And you may not really think about it at 50 or perhaps even 55 because it's not impacting you that much. But if you are the lady that I saw a few weeks ago who sits down in her garden to pee because she can't make it to even the front door to turn the key.
Oh, man.
That's significantly impacting her quality of life, right?
Yes.
And if she had come back not at 70, but had looked at that with us at 50 or 55, we probably could have stopped that happening, or at least Hannah could have stopped that happening.
Yeah, absolutely. So we didn't get to your client's story though, Hannah. Like let's sort of hear an example like what you just gave there, Megan, about something that you've helped a client with from start to finish, from where they were to where they are now. Okay, so I would say urgency symptoms are the ones that probably have the biggest impact on quality of life or participating in life, and that's because it's slightly less predictable. So stress incontinence, if you're leaking when you run, you know it's going to happen. You might put I might give someone a pessary to use, or you might put a pad in, you can contain it. It is when you have symptoms that come out of the blue. And with bladder urgency and bowel urgency, you can often lose quite big volumes in one time. So again, much harder to contain. So an example was someone who was going to stop working for bowel urgency. So she was a teacher, was at school, and she would get a very sudden, I've got to go and I've got to go now, classroom of kids, couldn't go, terrible, right? And then physio is really simple. Like, I think sometimes, you get a bit nervous about seeing a physio because you're like, what are they going to do? Do I have to do exercises on the floor with my pelvis? But it can be really simple strategies, like teaching someone how to empty their bowels effectively. You empty your bowels effectively, you're less likely to leak. Little tools around manipulating what types of foods you eat and how you eat them. And then foods, really?
Yes,
okay.
yeah. Well, like a cup of coffee. Lots of people will drink a cup of coffee and they'll be like, that's my signal to go to the toilet. And then pelvic floor exercises. So this person, big, massive difference.
Amazing.
So we got her under control. So again, don't be afraid to seek help would be.
I bet she could keep working.
Yes. Yeah. And so grateful.
Yeah. Because it could get that bad, couldn't it? That you couldn't work.
Yeah. And you just get more and more anxious. And anxiety does not help bowel control or bladder control. And it becomes a bit of a vicious cycle.
Absolutely.
Yeah.
Megan, are there any specific endocrine or thyroid conditions that can contribute to bladder dysfunction that women might not be aware of?
An overactive thyroid will make your bladder irritable. Yes. Underactive thyroid, I'm not really aware that there's an association with that.
It's interesting. Apart from constipation.
Right.
So
yes, you're right.
Yeah.
Constipation.
Constipation's not great for the pelvic floor either.
Right. Oh, well, that makes sense.
Yeah.
Absolutely. So the big thing with this whole topic really that I keep on hearing, and, I feel like I'm guilty of this too, is that people are just struggling to ask for help. Aren't they?
Oh, waiting too long.
Yeah.
So that would be the message is even when it's not inconvenient. would be the message. Mm-hmm. Your healthcare professional, hopefully they will bring it up and ask you, but if they don't, it's having the confidence to bring it up.
It's kind of why these conversations are so important, aren't they?
Yes, it's tricky, isn't it? Because at the moment our GP service is crumbling and you have 15 minutes with the GP and typically you go with a problem. So it's pretty tough for a GP then in the midst of all that to say, oh, well, what's happening with urinary symptoms and urgency and nocturia, getting up at night to pass urine and things. It's easier for me who has more time to do that. So if you can make an appointment to actually discuss this issue, yes, it's scary, but the other side of that is that you will absolutely improve quality of life with some good management.
Absolutely. And so, but how do people come to see you? Obviously private practice, but is there any way people can see an endocrinologist specifically funded?
There is endocrinology in all the public health systems across the country.
Yeah.
Auckland has some specific reproductive endocrine expertise, and Canterbury has some specific reproductive endocrine expertise.
And what would the wait list be like for something like that, though?
If somebody's being referred for menopause and urinary symptoms, typically the referral will be accepted if it's a complex menopause. So perhaps somebody who's had a clot in the leg or the lung, they've had a breast cancer diagnosis, they might have some heart disease. Typically in the public system, the straightforward menopause cases are felt to be primary care rather than secondary care given.
Interesting. And what about with you? So do you do any public practice stuff, or it's all private referrals through private health insurance, or people just paying for themselves?
Yeah. So we do have a public health physio service in Auckland at our 3 DHBs. So that's GP or even specialist referral in. There is a bit of a waiting list, so that's a big barrier.
There is
it's access. There's lots and lots of private pelvic floor physios now, and there is, like for maternal birth injuries, we do have ACC cover now, so that makes it slightly more accessible. So that might be a big barrier, it's just cost. But again, you pay, I think about like how much people pay to go to the hairdresser or things like that.
No.
And again,
Especially blondes.
If you're not just a one or two appointments, again, better to do that now than wait. The symptoms become much worse, and again, that has a much bigger cost.
So the next thing I was going to say, as we sort of wrap up, we talk about, accessing the support resources other than Continence NZ, where all of the information is there on the website. Is there anything else that you recommend to clients to seek out further information if they need it, anywhere that they can go, anyone they can talk to?
So our website, ERH Associates, has some really good evidence-based information on menopause and the genitourinary syndrome of menopause, open access. The Australasian Menopause Society also has some fabulous information, all evidence-based and open access to women.
Yeah, again, this is just not talked about, is it? It's just not talked about, and this is why we need to have this conversation. And what about from your perspective, like, what's a great place for people to go to sort of go, how can I find out more about pelvic health and, learning the exercises and that sort of stuff?
Or probably Continence New Zealand.
There you go. Oh, what a plug. I love it.
Yeah.
That's so great. And do either of you have sort of a final message that you just want to get out there, that's just something that you're really passionate, that you just want people to know other than this help out there?
Don't wait.
Yeah.
Go for help. If you encounter a GP who's overstretched and struggling, don't be put off. Just go and get some more help from somewhere else, because this will get worse with time if you don't get good treatment and management. And there's good treatment and management options out there.
Yeah, there really is, isn't there? What about you, Hannah?
Well, it's the same. And physios are not scary.
And, you don't seem to be.
Yeah. And you can self-refer. So even if your GP isn't able to, like, you get, again, stretched and you can't have a chat with them, you can self-refer to a physio. So very easy to access help.
Yeah. And can people self-refer to you? I'm guessing they can.
People can self-refer to our specialist menopause GP clinic.
Oh, wow. Okay.
And those are specialist GPs who are funded to have an hour with somebody, and they work with the pelvic floor just like I do. So they do a great job.
How valuable to know that exists. Again, didn't know that one either. And as I'm getting to that age and that stage, it's learning these things and sharing all of that. And now when we're standing having a wine, we'll talk about it, right? And that's the best part. I want to thank you both for joining me so much. Hannah Orr, pelvic physiotherapist, and Dr Megan Ogilvie, endocrinologist. What a chat. So many things that you can do to help improve and in some cases resolve these continence issues. This podcast series is going to cover many issues to do with incontinence, but we do encourage you to visit continence.org.nz. And if you'd actually like to speak to somebody, there is a continence helpline. Yep. There's people on the phone, 0800 650 659. They talk about bladder and bowel health all day, so there's nothing to be embarrassed about. It's what they do. No question is out of bounds. Thank you so much for joining me for this episode. We'll catch you next time. Mā te wā. Take care.